at the after the initial program, we will start the screen presentation.
Okay, sir.
Okay, so good evening, respected faculties and senior members in this platform. This is welcome you all again for the IAP Trivandrum and IAP Kerala joint venture of PG Club today. Today we are going to discuss a pediatric cardiology case. After the initial program, we will start the screen presentation. Okay, fine. To begin the proceedings, I welcome Dr. Riyaz sir, the president of IAP, to give the initial remarks. Good evening, respected faculties and senior members in this platform. This is welcome you all again for the IAP Trivandrum and IAP Kerala joint venture of PG Club.
Repeat it.
Okay, now it's fine. Now it's fine. Okay. Over to Riyaz sir.
So, welcome everyone once again to the IAP PG Club. So, we are all happy that there is very good attendance and the program is happening without any break. This time the program is hosted by IAP Trivandrum, and the Trivandrum team has curated a very good program. And I think it is after a long interval that we are discussing a cardiology case. And we have two eminent teachers, Dr. Lakshmi and our Harikrishnan, to discuss the case, and Dr. Arati is going to present the case. So I wish all the best, and back to Srijit for continuing the program.
Now I'll welcome Dr. Mohandas sir, Professor Mohandas sir, to give the initial remarks.
Good evening. Really happy that Trivandrum unit has organized this week's case discussion, and I would like to congratulate the office bearers of IAP Trivandrum and also the zonal coordinators, Dr. Sujit and Dr. Priya. As Dr. Riyaz has already mentioned, we are discussing a cardiology case, and the case is being discussed by Dr. Lakshmi, who is the HOD of pediatric cardiology, who is the successor of our Sulfi sir. And she has taken that department to greater heights, as we all know. A lot of interventions happening, a lot of, we all appreciate the hard work you are all doing. And Dr. Harikrishnan also is in the same department. And I would like to welcome you both for this program. And the case is being presented by Dr. Arati S. Kumar, who is the JR3 of Department of Pediatrics, SCT Hospital. So we will straight away go to the program. Anything else?
So I welcome Dr. Harikrishnan, the Assistant Professor of Pediatric Cardiology, to introduce the mentor. So mentor for this program, and introduce the presenter, and about the case also.
Thank you, sir. Thank you for the kind introduction. Today we have a 9-month-old patient who's been discussed. It is a very common scenario, common case that we see in the OPD, and all the postgraduates should know how to elicit these signs and how to make a diagnosis so that is what we are discussing. Although slightly atypical presentation, so we'll discuss the case. I would request Dr. Arati, our third year JR Pediatrics, to present the case.
Thank you, sir.
I request all the postgraduates to kindly participate in the interaction so that it is useful for everyone. Yes, please, Arati.
Okay. Thank you, sir. So good evening, all my respected teachers and my dear friends. So let me start by sharing the PPT. So is the PPT visible to everyone?
Visible, but not, okay, fine.
Okay. Okay, so let's begin with the patient biodata. So I'm presenting the case about Anne, who is a 9-month-old girl child hailing from Alappuzha. Her mother is Christy, 30 years old. Father is Vibin, 40 years old. The informant being mother, providing reliable information, and the date of examination was on 5th of April 2025. Coming to the presenting complaints, fast breathing, difficulty in feeding, sweating over forehead on feeding, and inability to gain weight. All these symptoms are noticed by the mother for the last 2 months. Now, coming on to the history of illness, since the symptoms and signs of the related condition has begun from the neonatal period, I would like to start from the neonatal period. So the child is a second live child to a non-consanguineous marriage with history of 2 spontaneous first trimester abortions prior to this pregnancy, born to a diabetic mother. She had over DM on insulin and metformin, and all the antenatal scans and fetal echo were done with normal results and with no other significant antenatal history and no history of intrauterine infections. And she was born as a term baby with normal vaginal delivery, with birth weight of 2.6 kg, cried soon after birth, no respiratory distress soon after birth, but had asymptomatic hypoglycemia on postnatal day 2 and neonatal jaundice on postnatal day 3, and hence a total neonatal stay for 3 days for these conditions. And while on NICU on postnatal day 3, an echo was performed, and after which the mother was informed the child had a congenital heart disease, which was likely to regress spontaneously with age, and was advised follow-up and a repeat echo later. And thus the baby was discharged from the hospital by postnatal day 5. And after discharge, the child remained relatively asymptomatic with no history of hospitalization till 6 months age. That is, till 6 months, the baby had no history of difficulty in breathing, fast breathing, like feeding difficulties, cyanosis, and had gained weight adequately during this period. And at 6 months of age, the baby was hospitalized with severe pneumonia, requiring ICU stay for 6 days, but was not ventilated, but received multiple IV antibiotics. So during this, repeat cardiac evaluation was done, and the mother was informed that congenital heart disease was significant, and that the baby will need a surgical correction later once the adequate weight was gained, and the baby was also started on 2 oral drugs. So following this hospitalization, since the last 2 months, the child is noticed to have increased fast breathing associated with lower chest ingrowing. There is no history of fever, cough, or rhinitis. And there is no history of relief of breathlessness with position. That is, no relief by putting on shoulders or such position. So for the last 2 months, also noticed to have excessive perspiration of the forehead while feeding. That is, the baby is having difficulty in feeding and also associated with suck cycle. There is feeding difficulty with duration of feeding lasting more than 40 minutes each time. There was failure to gain weight, remaining 5 kg since 5 months age, and no history of cyanosis, no history of edema, no history of decreased urine output, no history of fever with chills, and no history of recurrent fever, irritability, or any seizure activity.
Arati, can I interfere at this point? So can you summarize just the history of presenting complaints?
So we had a baby, a 9-month-old child, born as a second live child of a non-consanguineous marriage, born to a mother with overt DM on insulin and OHA, metformin. And the child was born as term AJ baby with nil significant NICU stay. That is, child had an NICU stay for asymptomatic hypoglycemia and neonatal jaundice only. But at that time in the NICU stay, because the mother had overt DM, apparently, so in the NICU, they performed an echo on postnatal day 3. And at that time, the mother was informed that the child had a congenital heart disease, which was likely to regress with age spontaneously and was kept under follow-up. Until 6 months, the child remained relatively asymptomatic with no history of feeding difficulty, no history of difficulty in gaining weight till 6 months. And at 6 months, the child had a severe pneumonia episode. And during that severe pneumonia episode, again, a repeat cardiac evaluation was done, and they were informed that the child needed a surgical correction for this congenital cardiac condition. And also the child was started on 2 oral drugs for the cardiac condition. Now, after that, after the 6 months age, the child is very symptomatic in the sense that child is having fast breathing, even at rest, with increased work of breathing, difficulty in feeding, and establishment of suck cycle history is there, and also decreased duration for feeding time, that is also is there.
So what does that indicate? What does that indicate?
All these symptoms are suggestive that the child is showing symptoms of cardiac failure.
So when you summarize, you can just say like that: the child has features of heart failure from the last 2 months. Okay, she was relatively asymptomatic till 6 months, And following a hospital admission for severe pneumonia, mother noticed symptoms suggestive of heart failure. Okay, when you summarize, you need not tell everything that you have described earlier. You can just tell like this: a baby had features suggestive of heart failure. And what else?
A failure to thrive is there, madam.
Hmm.
And that from the history we got that the cardiac condition, they were told told that the surgical correction will be needed as soon as possible. So
at this point, what would you like to think about differentials?
So
some other PGs can answer. Who all are there? Somebody can answer from the audience. So Aruthi was telling that it's relatively asymptomatic child till 6 months of age had a hospital admission for severe pneumonia, and after that mother noticed features of heart failure and associated failure to thrive. So with this history, what all differential diagnosis would you like to think? Any other pages in the audience?
Aradhi, from your history, how can you be sure that it is pneumonia? You mentioned a severe pneumonia, no? The admission is for severe pneumonia. How did you confirm that? I mean, what did you ask the mother?
At that time, child, its respiratory distress started with upper respiratory infection symptoms. Fever, cough, rhinitis was there at that hospitalization. Prior to that, after that, the fast breathing was associated with fever also, and required IV antibiotics. That is what history have asked for.
So yeah, it could be a pneumonia, but it could be a heart failure admission itself.
At that
right?
time. Yes, sir. That
could be heart failure also.
Yes.
So I think based on history, you can tell that it can be pneumonia, but you cannot be very sure that it is pneumonia which required ventilation.
Yes, sir. The child was not ventilated, but was required O2 support, but was not ventilated.
So what are your differentials at this point?
Nobody else is answering. Should we call out or? No, all our PGs are all there, but they're not answering. Okay, Arathi.
So the first AD will be the child is having an acyanotic congenital heart disease in cardiac failure. So most likely it can be a post tricuspid left to right shunt, like VSD, PDA. AP window is also possible, though it might present at an earlier age, and by 9 months it will be like more symptomatic earlier itself, and might require intervention when was diagnosed as at postnatal day 3. And
no, but VSD and PDA, is this the typical age of presentation of a VSD or a PDA?
No, sir. Actually, a VSD usually presents by 6 weeks. As soon as the pulmonary vascular resistance comes down below a critical level, the VSD can manifest. So it manifests as congestive, like cardiac failure, by 6 weeks of age, as early as 6 weeks, but not before that. So it usually does not remain asymptomatic till 9 months, like in our history.
Till 6 months.
Till 6 months.
So that's a point against a post tricuspid left to right shunt.
Yes,
okay. But post tricuspid left to right shunts being the commonest cause of heart failure in infants, you have to consider it. But the point which is against that is the late presentation. Usually large shunts usually presents earlier by 6 to 10 weeks of age. So what can be the other differential diagnosis?
Madam, obstructive lesions can be considered, like severe aortic stenosis or coarctation of aorta, or regurgitation lesions like severe.
We'll come to, we can stop at the obstructive lesions. That is more likely than a post tricuspid shunt with the history. Okay, the obstruction may not be severe in the initial period, that can progress. So by 9 months, 6 months, it would have become severe aortic stenosis and child would have presented with features of heart failure. So based on the history alone, that is more possible when compared to a post-tricuspid left to right shunt. Okay. Then what else?
Madam, viral myocarditis, or because by 9 months age, it can also present in cardiac failure.
And what are the points in favor
Mm,
of viral myocarditis or a cardiomyopathy, decompensated cardiomyopathy? What is the point in favor of that from the history?
Till 6 months of age, child was asymptomatic. So after that infective phase only, the child has started symptoms of cardiac failure. So
and
that
all
is
the symptoms started after an admission, hospital admission for likely pneumonia. So that is a point in favor of myocarditis or a decompensated cardiomyopathy. And what is against it?
Failure to thrive, that is established already.
Failure to thrive can be there. Any heart failure can cause failure to thrive. What is the point against a myocarditis from your history? They were advised
started on 2 drugs. The child was started on 2 drugs. They said
that is not against myocarditis. They were advised surgery at later, no?
Yes.
They were advised need for surgery. So that is the point against viral myocarditis or a cardiomyopathy. So based on the history, the obstructive lesion should come first, followed by a left to right shunt. Then it can be a viral myocarditis, but the point against is that patient was advised surgery. Then anything else?
Can you tell some other conditions which can cause heart failure in this age group? Infancy.
Sir, other conditions like AV canal defect can cause, even though
we have already mentioned that, no?
That's a shunt. It is like a VSD. AV canal, though AV canal, it is like a VSD presenting. So that is also a left to right shunt presenting with failure. Any other conditions?
Sir, conditions like systolic or diastolic dysfunction, like dilated cardiomyopathy or hypertrophic obstructive cardiomyopathy, or
yeah, somebody has already typed it.
Parvati can answer.
Al-Kappa can present at this age.
Yeah, very good. Very good. Al-Kappa can also present. Usually the presentation is slightly earlier, but delayed presentation can also occur. And that also following decompensation, maybe following a hospital admission. So it can occur. Al-Kappa can present like this. Anything else from the audience? Other participants?
We have mentioned left to right shunt, systolic dysfunction, then the coronary abnormality, Al-Kappa, then obstructive lesions. Anything else? Okay, arrhythmias. Dr. Chinnu has told arrhythmias. So any tachycardia can cause systolic dysfunction due to the tachycardia itself. Okay, so tachycardiomyopathy, that is called. Anything else?
Also,
any other rarer conditions?
Ostium primum ASD with an MR.
Okay, that's also a very good possibility. If it is an ASD, it should be a associated MR which is causing heart failure. You cannot tell that an ostium secundum ASD has caused heart failure. Some associated lesion which increases the left atrial pressure, like ostium primum ASD with mitral regurgitation, that can cause heart failure. Anything else?
DCM we have already discussed, comes with myocarditis.
I think the common ones are these.
Okay, so you can summarize the differentials based on the priority from your history. So first should be
post-tricuspid left to right shunt.
Based on your history, first should be an obstructive lesion, because usually post-tricuspid shunts presents earlier. So obstruction can be diagnosed at birth. They can remain totally asymptomatic and can later present. Obstruction can progress and they can present with heart failure. So first should be an obstructive lesion, like severe aortic stenosis or severe coarctation. Second can be post-tricuspid, left to right shunt. Third possibility can be an L-kappa. Fourth can be a tachycardiomyopathy. Fifth can be a viral myocarditis or a decompensated cardiomyopathy. Okay, cardiomyopathy can be secondary to Pompe's also. So somebody has told about Pompe's disease. So that comes under dilated cardiomyopathy. So based on the history, these are your differentials. Okay, now we'll proceed with the further.
Okay, madam. So coming to the nutrition history, the child was exclusively breastfed till 6 months age, and complementary feeding started by 6 months. By 24-hour recall, the total calories were 520 kilocalories per day. The required was 660 with a deficit of 140 kilocalorie per day, and there was a protein deficit of 1.5 gram per day. Developmental history, grossly coming to all domains, the child was developmentally normal and attained milestones appropriate for age. Immunization history, the child was partially immunized for age as per NIS, due for 9 months vaccine. And the last vaccine taken was at 14 weeks. There was a BCG scar present, no history of AFI and no optional vaccines taken. Family history, the child was second live child of a non-consanguineous marriage. There was history of 2 spontaneous first trimester abortions prior to this pregnancy. And there is no history of heart diseases in family. Socioeconomic history, the father studied up to 12, mother graduated BA. The family belongs to class 3 lower middle as per modified Kuppuswamy scale. The total family members were 4 and there's no overcrowding in the house. Madam, can I summarize?
Yeah.
So we had a 9-month-old girl child, developmentally normal, partially immunized, who was born as a second life child to a non-consanguineous marriage to a diabetic mother with no significant antenatal history or intrauterine infections, and born as a term AGA, cried soon after birth. No history of respiratory distress in neonatal period, with a congenital heart disease diagnosed at postnatal day 3 and was advised follow-up for it. Remained relatively asymptomatic till 6 months, but was hospitalized with pneumonia at 6 months. Repeat cardiac evaluation during that time revealed a congenital heart disease for which they were advised for a surgical correction and was started on 2 oral drugs. And after that, noticed to have symptoms suggestive of heart failure, and there was failure to gain weight.
So what are the symptoms of heart failure? You said symptoms of heart failure. So what are the symptoms of heart failure in an infant?
Lakshmi.
Oh, sir.
Arathi, a few comments about the overall history part. When you are presenting the slides, always few sentences only in a slide and never do like this.
Okay, sir.
You should be narrating this thing. It should not be reading. That is one thing. And about the diagnosis part, somebody found a murmur and did the echo. What was the basis of that decision of the echo is to be mentioned? Is it because some finding detected by the doctor or something else? Any cardiac problem delivered, now the neonatal screening programs need to be mentioned. The visible birth defect situation, pulse oximetry, other these things of cerebrum part, it's very important for a pediatric postgraduate. Is it because they found something abnormal in the screening is very important. So that is one thing. And the next thing, the advice by the doctor sometimes may be misleading. So don't discuss too much about what was found, what was advised and all. So of course, some murmur was found and somebody said it will close it. That's an important, useful point, but it may not be reliable sometimes. So in this case, very important, this is a case of congestive failure. The odd thing is that the initial months, it was asymptomatic and later presented with severe failure. So what is the possibility in that context? Whenever you are basing on these things, there should be a documented weight which will be available in the immunization card. So 5 kg, and from that period onwards, it was not gaining weight. 5 kg roughly will be achieved in a 2.6 birth weight kg around 5 months, not 6 months. So after 5 months, there is no gain in weight. So anyway, was that a documentation is very important. Okay. After that, definite history of congestive failure is there. So it is against the usual presentation of the commonest of the condition post-tricuspid VSD or PDA that will be presenting much earlier, even when a murmur is seen, but the failure usually starts after 1.5 months or 4 to 6 weeks, and it was not presenting out according to you. So when a left-sided thing is not presenting, as already we discussed, it can be a situation of pure left-sided obstructive lesions, or there can be a small left or right shunt VSD or PDA with another small obstructive lesion on the left side, which is exaggerated. All the other possibilities already discussed. What are the possibilities? Out of which I think I would like to add anemia and hypertension also. So hypertension is not a common condition, but can be some other reason hypertension. Any left-sided obstructions in the form of a structural or a pressure likely to worsen the left-right shunt. So you need to consider whenever there is an atypical presentation of congestive failure, and infective endocarditis need to be considered, not in this case because long duration without fever, it's unlikely, but all the situations, if an acute problem worsening later, infective endocarditis also, hypertension and other thing also need to be considered. Arrhythmia, definitely. All the other things discussion. Now, one thing about the myocardial disorders, there is no need to elaborate different possibilities. Some myocardial dysfunction. There are few possibilities where the myocardial dysfunction, myocardial part can be combined with the structural problem. Especially some of the conditions like Noonan syndrome and all, you get a stenotic lesion, but usually stenotic lesion on the pulmonary, but other things are also possible where there can be HOCM superadded on to that. So we need to consider a combination also. Okay, Lakshmi.
Yes, sir. So what are the symptoms of heart failure in an infant?
Madam, exertional dyspnea or particularly feeding difficulty, madam. That is the main symptom. That is
what causes dyspnea? What causes dyspnea in a child with heart failure? What are the mechanism of dyspnea in a child with heart failure?
One, madam, due to increased pulmonary blood flow, it can cause like compression over the bronchioles, and hence.
Is that the reason?
Or
Parvati, what causes dyspnea in a child with heart failure?
Madam, increased blood flow, like increased blood flow that can lead to exudation, like transudation of fluid into the alveoli can cause respiratory distress in the baby.
Transudation of fluid into the interstitium. Okay.
Somebody has written pulmonary venous congestion. Pulmonary venous hypertension, basically. Pulmonary venous hypertension.
Arida, you can show that slide of some differential diagnosis. So we'll analyze based on each type. Can you show that slide? So what causes dyspnea in a post-tricuspid left to right shunt? Parvati has already said there is increased pulmonary blood flow. So there will be interstitial edema, lung compliance will be reduced, and that increases the work of breathing. So that causes dyspnea in a post-tricuspid left to right shunt. What happens in obstructive lesions?
Obstructive lesions, there will be fixed cardiac output, madam. So during. Hello.
Oh, is the fixed cardiac output the reason for dyspnea? Is that the reason for dyspnea?
No, actually, due to fixed cardiac output. So when there is exertion or when the child is exercising, or whenever there is exertion, there will be increased demand by the organs. So that is not met because of the obstructive lesion. It's because it's a fixed cardiac output. So that can cause dyspnea in obstructive lesion.
No, that is not the correct explanation. That is not the correct explanation. Yeah, Arlen has written high left atrial pressure. So that is the reason. Okay, left ventricular end diastolic pressure will be elevated in a severe AS or coarctation. So left atrial pressure will be elevated. That translates to pulmonary venous hypertension because pulmonary veins are draining into the left atrium. Okay, so left elevated LV end diastolic pressure, elevated left atrial pressure, and hence elevated pulmonary venous pressure. That is a mechanism of dyspnea in an obstructive lesion.
And in any situation, whether it's LV dysfunction, like L-kappa, viral myocarditis, dilated cardiomyopathy, increased LA pressure and pulmonary venous congestion is the cause for dyspnea. Whereas in post-tricuspid left to right shunt, it is pulmonary. Increased blood flow. Okay.
Dr. Hari and Lakshmi they were pointing out, unless there is a left atrial increase in the pressure, you won't have a congestion, you won't have dyspnea. So in any case of outlet obstruction like AS or coarctation, initially the LV will take the whole burden to squeeze out the blood into the aorta, and the left atrium will not know the problem. So only when the LV dysfunction starts in an obstructive lesion, we'll start having left atrial pressure increase. So in a case of AS or AR or whatever, early manifestation dyspnea will not be there. Left ventricle will bear the whole effort. Okay. So that means always LV dysfunction due to whatever reason will only lead to dyspnea. Okay.
Okay. So what are the other symptoms other than dyspnea and feeding difficulty?
Madam's feeding difficulty. Then other than that, increased respiratory rate, work of breathing, failure to thrive is also.
Diaphoresis. Somebody has mentioned diaphoresis. So why do they sweat? Forehead sweating is also a symptom of heart failure, no? In infants. Why do they have increased sweating of forehead?
Yeah, sympathetic overactivity, right? Sympathetic overactivity. Madam, I think your video is pausing in between.
Yes, somebody has written. Okay. Okay.
So the sympathetic overactivity. What is the cause for failure to thrive in a left to right shunt?
One is mainly due to feeding difficulty. Failure to thrive can occur.
Okay, so the intake is reduced. Okay, intake is reduced. Then what are the other causes? Anyone can answer. Though the questions are directed to Aarti, anyone can answer. Yeah, so recurrent respiratory tract infection, right? That is one of the most common presentations, no? Recurrent respiratory tract infections that can cause failure to thrive.
Yes.
What else? So decreased intake, recurrent respiratory tract infections. What about the demand? Yeah, basal metabolic rate is increased. No? They have to do a lot of work to feed. Yes. For all the activities, their work is increased. So increased demand, reduced intake. Along with that, recurrent respiratory tract infections. Even their gut motility, there are differences in the gut motility because of decreased gut perfusion. Already somebody has mentioned. So, and many of them may be syndromic, right? Many of the congenital heart diseases may be syndromic. So all these are the reasons why they have failure to thrive. Okay. What is the reason for recurrent respiratory tract infections?
Pulmonary venous congestion is or is
What causes recurrent respiratory tract infections?
Increased pulmonary venous hypertension or pulmonary venous congestion can cause.
How does that cause infections?
Because the innate
Anybody else would like to answer? How does left to right shunt cause infections? Increased respiratory tract infections.
Low flow, increased pulmonary blood flow. What will happen when the pulmonary blood flow increases? Pulmonary overcirculation. So what will happen to the decreased mucociliary clearance? Okay, that is the explanation. So when there is pulmonary congestion, the mucociliary clearance will be decreased, and so they will be prone to have recurrent respiratory infection. Okay. So Aridi, can you summarize the causes of failure to thrive in a heart disease?
So first is due to decreased intake due to increased exertion on or difficulty in feeding. Or due to difficulty in feeding, and due to second cause is due to recurrent respiratory tract infections, and also due to increased demand of the child. There will be increased basal metabolic rate, and other causes decreased absorption from the gut due to the decreased
due to intestinal congestion. So there will be decreased intake, decreased absorption, and increased metabolism.
Demand.
Increased demand is also there. Then you have already mentioned. I just told you to summarize. Maybe associated chromosomal anomaly.
Yes.
Maybe due to associated GERD. Most of the children with heart failure, you have seen that they will be having GERD-like symptoms.
Yes.
And they will have recurrent respiratory infection, hospital admission, decreased appetite. All this can contribute to, they may be on multiple drugs. All this can contribute to failure to thrive. Okay.
Arati, just because Hari sir and Lakshmi already point out, you need to elaborate a little bit more on the dietetic part and the family history. Okay, the very same reasons, because the surgery may be needed, but they may hesitate for a lower weight child. So a little more about the feeding pattern, what are the contents, how are they giving, because main management in the early period is to provide 1.5 or double the nutrient requirement, including the micronutrient, in a different manner. High calorie diet, small frequent feeding, maybe tube feeding. In this case, the family history is important. There are 2 abortions in the first trimester. Consanguinity, you mentioned consanguinity, I think. But in the family history, you told there is no history of cardiac disease only. It's not the only one. There can be associated stigmata which may be associated with a cardiac lesion. So it is not the negative history of cardiac problems. Any syndromic situation or likely associated conditions in the family history also are important. Okay. Because the associated genetic malformation, Lakshmi Madam was pointing out, may lead to GERD situation, which may be or a H type of tracheoesophageal fistula. They all may contribute to the pneumonia and the feeding and failure to gain weight. So history part, when you're talking, relevant areas need to be a little more highlighted, because that is the thing based on which you're going to decide on the feeding, how I am going to rectify the feeding part. Okay.
Okay, continue.
I think, can it be a cyanotic heart disease?
Yes, sir. Like conditions like truncus arteriosus or TAPVC can also present with
So
failure.
what is that group called together? What kind of cyanotic heart disease can present like this?
Conotruncal.
These are cyanotic heart diseases with increased pulmonary blood flow, right?
Yes.
So they are called admixture. They are usually admixture lesions. There's complete mixture of blood in a vein or in a cardiac chamber without any stenosis of the pulmonary valve. So admixture lesions without pulmonary stenosis. All those will have increased pulmonary blood flow. If they are mildly cyanotic, they may be missed. Okay, so it's very uncommon in our setting because routinely we do pulse oximetry, but otherwise mild cyanosis can be missed. And the conditions like you told, TAPVC, truncus, single ventricle, all those conditions. Yeah, go ahead.
Madam, so coming on to the general examination, the child was active, alert, and playful on examination. The vitals were the temperature was 98°F on right axilla. The pulse rate was 122 per minute. Normal volume, normal character, regular rhythm, no radiofemoral delay, bilateral peripheral pulses palpable equally. The BP was 90/56 in the right upper limb in supine position and 94/50 in the right lower limb in supine position. The respiratory rate was 66 per minute, and there was work of breathing increased as was seen as the intercostal retractions and the subcostal retraction. The SpO2 was 96 in the right upper limb and 98 in the right lower limb. There was mild pallor and there is no icterus, cyanosis, clubbing, lymphadenopathy, or edema.
So after the vitals, what all the differential diagnosis, what all diagnosis from the differential can be excluded?
Madam, one PDA has a bounding pulse, so PDA can be ruled out from pulse by examining the pulse volume.
Anything else other than PDA?
Obstructive lesions like aortic stenosis can also be ruled out here because the BP is normal.
Pulse is also normal volume. Okay, that rules for significant aortic stenosis. Then
and peripheral pulses are palpably equally, so COA is also ruled out.
Okay. You can rule out an AP window also. Less likely in this child, but AP window. Normal pulse volume rules out a PDA, AP window, and all peripheral pulses are equally palpable, so that rules out an coarctation. And normal volume pulse rules out severe aortic stenosis, and BP is also on the normal side. Okay, and saturation, you got saturation as 96% and 98%. So
conditions can also be ruled out, madam.
Many of the admixture lesions can also be ruled out. Okay.
Can you just tell how the pulses will be in those conditions which you excluded? What will be the character of pulses?
A PDA, it's a bounding pulsar, and the BP would be wide pulse pressure will be there. And in case of coarctation of aorta, we said peripheral pulses, it won't be palpable equally. Then
so
in case of aortic stenosis,
what will be the typical finding in a coarctation?
There will be difference, sir. So like the lower limb will be the pulse volume will be different, sir.
Pulse volume will be different and pulse volume will be different, and already somebody has written radiofemoral delay will be there.
Yes.
Pulse volume will be different. And AS, what will be the typical pulse in an AS?
Its pulse volume is low. Pulse volume is low in an aortic stenosis.
But further characterize that AS pulse. Yeah, already answers have come, but in this pulses, what is it called? Yeah, what is it called?
Pulsus parvus.
Et tardus, no?
Pulsus parvus et tardus.
Low volume and a slow rising pulse. Okay.
Arati, there is a higher rate, a little higher rate for a 9-month-old baby, 122. There you need to mention always, did I repeat the pulse rate? Was he having fever? Was he having anemia? Was he on salbutamol or any drugs?
Okay.
Was a little on the higher side. Is it because the congestive failure uncontrolled? Maybe the most likely thing. So, and the other BP, whenever you're recording a BP, better to mention the centile also. Okay. Important.
Okay.
And Hari was pointing out, in this case, when you consider a cyanotic lesion, the mere presentation of pulse and all, I'll check the carotid pulse for the slow rising. It's very important. It's not the radial pulse or femoral pulse. The character is to be checked at the carotid, not the volume, but the slow rising aspect is more important. And BP again, when you're recording the BP, what you're expecting is a 10 millimeter difference in both systolic and diastolic situation. Here you didn't get it, almost same, or the diastolic BP, if you're looking 56 and 50.
50.
A little bit suspicious, that's all. The timing is very, very important. Radiofemoral delay timing is important, but the BP difference, if it is same also, you need to be suspicious. Okay. You expect with the same BP apparatus measurement, you expect a little 10 on the higher side. So here diastolic is a little lower than the upper limb. So maybe if you repeat the whatever thing which are doubtful, more important, you need to repeat, check again and again, then only present. Okay. Okay.
The child appeared malnourished with the hair being dry and brittle. Shape of skull was normal. The AF was at level 1.5 to 1.5 centimeter, and there was no obvious facial dysmorphism, no cyanosis, no cataracts, no bited spots to look for vitamin deficiency. There is no oral thrush to look for immunodeficiency. So there is no angulostomatitis, cheilitis, no dilated vessels noted over neck, chest, or abdomen. There is no clubbing, no rachitic rosary or Harrison sulcus. The spine was normal. There is normal female genitalia and no sacral edema. Coming to the growth assessment, the weight was 5.1 kg, which was less than -3 standard deviation for 9-month-old. Length was between 0 and -2 standard deviation, that is 66 centimeter. The weight for length was again less than -3 standard deviation. And the impression was severe underweight and severe wasting. Coming to the developmental assessment, it was normal. Supine pull to sit, good head control, ventral suspension, head above line of trunk. The child was putting weight on hands with extended arms, but soon getting up to sit with support and does not attempt to crawl. And pulls to stand and stands with support. Immature pincer grasp is there and says bisyllables, waves bye-bye, vision and hearing grossly normal. One thing was that the child by 9 months was not attempting to crawl that much, maybe due to difficulty, exertional dyspnea. So coming to system examination.
When you are appearing for an examination, it's not the cardiologist, pediatricians will be assessing you. So the growth and the development part, we're very cautious when you're presenting here. The head circumference is 42 in a 9-month-old baby, and you move forward without commenting on that. So, because you expect the 43 centimeters by 6 months, so a little on the lower. So you need to mention about the head circumference of the parents there, and weight, height, always you need to mention it is on the lower side, mid-parental height and all. Charts should be following in an examination, especially it's very important in a malformation. Okay, you need to comment about it. Okay, normal. Okay, go ahead.
System examination, CVS. The pulse rate was already discussed, 122 per minute, normal volume and character, regular rhythm, no radiofemoral delay, and bilateral peripheral pulses palpable equally. The BP was 90-56 right upper limb in supine position and 94-50 in right lower limb supine position. JVP could not be assessed. Inspection, the shape of precordium was normal. The apex beat was visible below the left nipple. There is no visible scars, pulsation, or dilated vessels. palpation, the apex beat was felt in the left sixth intercostal space at the midclavicular line, and it was forceful in character. There was grade 2 left parasternal heave, and epigastric pulsations were felt. There was palpable P2, and no thrill was palpable. Percussion was not done. Auscultation.
So before auscultation, what will be your impression from these inspection and palpation?
Sir, there is cardiomegaly is there because
Okay.
the apex it's felt as left sixth intercostal space at midclavicular lines. The child is 9 months old and it's forceful in character. There is grade 2 left parasternal heave and epigastric pulsations. So there is an RVH, right ventricular hypertrophy is there. Palpable P2. So we are having pulmonary hypertension possible with these findings. So we can say that child is in cardiac failure with cardiomegaly and right ventricular hypertrophy with pulmonary artery hypertension also from these palpation findings.
And what does forceful at apex indicate? Is it normal?
No, madam, it's not normal. It was not sustained throughout the systole, like it would be heaving in AS. So it was not.
What does forceful apex indicate? Here it's forceful, no? So what does that indicate?
Madam. RVH is there, madam, but
forceful apex means
the fingers were elevated.
No. What does forceful apex means? It elevates the palpating finger and is not sustained. But what does that indicate? When you get a forceful apical impulse, what are the possibilities?
What overload?
Volume overload
of
LV. Volume overload of LV.
That means LV is volume overloaded, no?
Yes.
So, which are the conditions which produce LV volume overload in a 9-month-old?
VSD.
Yes.
VSD, PDA.
Yes.
AP window.
Yes.
Then ASD with the ostium primum ASD with
MR.
With MR.
Need not be ostium primum ASD need not be there. Any MR can also produce congenital mitral regurgitation, can produce LV volume overload and forceful apex. Then
severe AR.
AR is very rare in 9-month-old.
Out of your differential diagnosis,
AS, but
AS, what is the type of apical impulse in AS?
Heaving.
Heaving. Where AS will have heaving apical impulse. What is the type of apical impulse in DCM and myocarditis?
Don't know. DCM.
Myocarditis.
Don't know.
Can be forceful.
Okay.
So from your palpation, you're getting features of LV volume overload plus right ventricular hypertrophy. Okay, and pulmonary hypertension.
Yes.
Okay.
In the palpation, you have missed one palpation. Where else should you put your finger? Especially in this case? Both tricuspid shunt you considered?
Yes.
Okay. Where else will you palpate? You consider the possibility of a left-sided obsession on one side. Another one is a post-tricuspid shunt. Where else will you keep your fingers for and what? Suprasternal notch.
Okay.
What?
Sir, suprasternal notch, sir.
For a PDA, there can be a pulsation. It need not be VSD or whatever. It can be a combination also. So
Okay.
whenever you are getting a PDA or a VSD, or maybe there
Right.
can be an associated lesion, out of which one is an associated PDA. Another one we considered here is an AS. Okay.
Yes.
Question part.
Carotid.
So there can be a thrill in the
Carotid.
the carotid and suprasenal notch also.
Mm.
So put your finger there also. You are actually palpated all the apex, left parasolae, epigastrium. Okay. Suppose there is no epigastric pulsation, but a grade 1 LPSH. What additional reason can be considered? No epigastric pulsation, but grade 1 LPSH.
Mm.
What are the reasons for LPSH? That's why my question. In this case, it's clear. It is
That's RV.
RV, and what else can be? What else can produce a LPSH? Left atrium. Okay. Left atrium enlargement only can produce an LPSH, but here LPSH is significant and the epigastric pulsation is there. So we need to mention about the palpable second sound, LPSH and epigastric pulsation. So that means it is a pulmonary hypertension itself. It's not a mere dilatation of the LA producing for a little bit of lift. Okay.
Okay. Coming to auscultation, the S1 was normally heard, S2 was wide split with loud P2, and there was an LV-S3 over the apex, and a 3/6 pansystolic murmur at left lower stern border, which was not radiated, and a 2/6 mid-diastolic murmur at the apex. So, from this, Madam, LV-S3
summarize.
So basically, on examination, what we found was there was tachycardia, tachypnea, increased work of breathing, even at rest. And the child was severely underweight and wasted. Wasting was there, and mild pallor was there. So on system examination, there is cardiomegaly, palpable P2, left parasternal heave at epigastric pulsations. So what we have discussed, what there is features of cardiac failure, and on examination, there was cardiomegaly with LV overload and right ventricular hypertrophy and pulmonary hypertension features were there. So we had a wide split S2 with a prominent P2 and an LV-S3 at the apex. So LV-S3 at the apex means there is again a feature of left heart failure, and grade 3/6 pansystolic murmur at LLSB, which was characteristic murmur of a VSD. And since the VSD is large, it's a large VSD, that's why we are getting flow murmur at the apex also, which was what we got as the 2/6 mid-diastolic murmur at the apex. So that was actually flow murmur that by relative MS, or it was actually flow murmur. So from this, we can understand that the VSD was large.
What does LV-S3 indicate in a VSD? Presence of LV-S3 in a VSD. What does that indicate?
It means it's a significant shunt. It's a large VSD that has caused volume overload in the LV and is resulting in features of cardiac failure. So LV-S3 is established.
What causes LV-S3? It's due to increased flow across the mitral valve. It's not due to LV dysfunction. Okay. Not a feature of heart failure. In VSD. In VSD, it is due to increased flow across the mitral valve. Similar to MDM, it's a flow. Increased flow through the mitral valve causes LV-S3.
Arati, here in the auscultation, you mentioned about the second sound widely split and you just move forward. Second sound widely split and second component, and you move forward.
Yes.
You are telling there is an MDM and S3. So a little bit difficulty you will be finding in this case because there is a significant cardiomegaly, there is an MDM, there is an S3, and the analysis of the S2 is very important. Okay. It's very difficult to assess the ST split and all in a 9-month-old baby. Still, it is so important. What is the importance here? Lakshmi Madam will be explaining that, but the S2 is a little difficult to explain. Why is it important? What do you expect?
What will be the S2 in a large post-tricuspid left to right shunt? Like VSD. We'll take the VSD first. How will be the S2?
It will be a wide variable split will be there, madam, in
Okay.
VSD.
Why is it wide split?
Because during inspiration, there is increased venous return to the right side of the heart, and the left to right shunt will be decreasing at that time.
Is that the reason? What is a normal second sound? So before discussing in VSD, we will go to
A2.
normal second sound. What is a normal second sound?
It will consist of an S2, A2 and P2, which is due to closure of the aortic valve first and followed by the pulmonary valve. And that split is noticed at the left second intercostal space.
No, that is not
during pulmonary area.
No, normal second sound is A2 followed by P2, which is split in inspiration and single in expiration. With P2 softer than A2. That is a normal second sound. So when you say second sound is normal, it means that A2 is followed by P2, which is split in inspiration and is single in expiration. And P2 is softer than A2. Okay, that is a normal second sound. What happens to a second sound in VSD?
It's the A2. The split will be wide, madam.
It split becomes wider. Why does the split becomes wider? When can the split become wider? Either A2 should be early or P2 should be late. Okay, what happens in VSD? What happens to A2 in a VSD? When the LV ejects, part of the blood will be going into RV. So, LV to aorta flow will be less. So, A2 occurs early. Understood? A2 will be early in a VSD.
Yes,
early. And what happens to P2?
It will be late.
Late. So, early A2 and a late P2 causes wide split second sound in a VSD, but it's variable. It varies with respiration.
Inspiration and expiration.
The split becomes more in inspiration. So, wide variable split. And what happens in a PDA? What happens to how will be the second sound in a PDA?
In PDA, it will be a narrow split, madam. Narrow. The A2 P2, it will be narrow. The split
Why
is narrow.
It narrow? Why is it narrow?
Because in diastole, there is more blood flow going into the aorta.
Diastole more
from aorta to the pulmonary artery.
So how does it makes A2 second sound narrow split? What is the explanation for narrow split second sound in PDA?
A2 will be late, madam. A2 will be late because of the increased flow.
Increased flow from LV into aorta. Only after going into the ascending aorta, the blood is going through the PDA into the pulmonary circulation. Okay. So the LV stroke volume will be increased. So A2 will be delayed. And in a large PDA, sometimes the A2 can even happen after the P2. That is called paradoxical split. So in a PDA, the second sound is narrow split or paradoxical split. Okay. VSD, it is wide but variable split. And how is the second sound in ASD?
Wide and fixed split, madam.
Wide and fixed split. So second sound is very important in the diagnosis. Okay. Maybe difficult to understand the nature of the second sound in small babies, but that is very important in diagnosis. So you said, when you said wide and variable split, it cannot be a PDA. Okay. Okay.
What happens to the S2 in a VSD with severe pulmonary hypertension? P2 will be loud. P2 will be loud. I'm asking about the A2 to P2 interval. Will it be there? Will it shorten or widen?
In severe pulmonary hypertension, there will be the P2 will be earlier, sir. So it will be narrow. It will tend to the interval will tend to be narrow.
Interval will tend to be narrow, or it could be even a single sound. Okay, could be a single S2. Can you explain why?
Because of pulmonary hypertension, the left to right shunt is again further decreasing as pulmonary hypertension is increasing. So like
Okay,
that.
so
Since the shunt is decreasing, so the pulmonary valve will tend to close earlier because of.
that is not the explanation. Any other?
Anybody else?
What decides that A2 to P2 interval? Normally, also what decides that?
Amount of blood that is filling the ventricles and the time taken for.
Amount of blood going through the valve, even after the pressures have become the same, right? From the ventricle to the aorta or ventricle to the pulmonary artery, the blood will continue to flow for some more time, even after the valve is supposed to close. When the pressure of the pulmonary artery exceeds RV or pressure of aorta exceeds LV, valve is supposed to close, but it closes slightly later. What is that interval called? Yes, Gayatri has mentioned hangout interval. It's called hangout interval, right? That means from the pressure crossover, that means when PA pressure becomes more than RV pressure or aortic pressure becomes more than LV pressure, from that time till the actual closure of the valve. We expect valve closure when the pressure crosses over, but the valve closure occurs slightly later. So that is called hangout interval. So that hangout interval of the pulmonary artery is larger than the aortic hangout interval because the pulmonary artery pressures are lower, but resistances are very low. Pulmonary resistance is very low compared to the systemic vascular resistance. So the resistance of the distal vascular bed determines the hangout interval. Okay, since pulmonary vascular resistance is very low, pulmonary hangout interval is higher than aortic hangout interval. So that is why there's a delay A2 to P2. So in PH, what happens? Pulmonary vascular resistance also increases almost equally to the aortic hangout interval. So they appear closer, and then finally it may become a single sound. Like VSD Eisenmenger, usually you don't get a split S2. It is a single S2. Okay.
Arathi, what is the difficulty at this stage? You will find it to explain. Till the palpation stage, what was your possibility you considered was? There was an LPSH, there was an grade 2 LPSH, epigastric pulsations, okay. And you postulate the possibility of an pH, a little significant pH, okay. Now at this stage, what are you saying? Palpation, apex is in the 6th space, there is a third heart sound, there is an MDM.
Yes.
And the A to B2 interval is wide. You didn't mention about the variable or wide. Okay. So what is the difficulty here?
Because since I didn't mention, it can be an ASD with right.
Sir was pointing out what changes do you expect with the pulmonary hypertension. Okay. So what is the difficulty here?
So is your findings compatible here with a large VSD with pulmonary hypertension? Is your second sound, you said wide split with loud P2, is it compatible?
Madam, question was not clear.
You said it's a large VSD with pulmonary hypertension. Okay.
Yes. Yes.
So is your second heart finding of second wide and wide split, variable split with loud P2, is it going with your diagnosis? That is what sir was asking.
Yes, madam, it can be.
Yes.
Yes,
it can be like that. Why?
Yes. Because VSD is causing volume overload in the PA, LA, and LV. So that can result in a cardiac failure and the pulmonary hypertension to occur.
So here, even though there is pulmonary hypertension, it is a flow-induced pulmonary hypertension, no?
Flow-induced,
it's a hyperkinetic pulmonary hypertension and not obstructive. What Hari was discussing is the obstructive pulmonary hypertension, when the pulmonary vascular resistance is very high, then you will not get a wide split second sound. But
Okay.
from your findings, it is a hyperkinetic pH.
Mm.
Okay. Why
Yes,
do you
ma'am.
say it's a hyperkinetic pH?
Because there is cardiomegaly, and pulmonary hypertension is there, hyperkinetic cardiomegaly. When we have the X-ray also, it will be.
No, clinical examination. Starting from the symptoms, why do you say it is a hyperkinetic? What happens when the child goes into obstructive phase?
In obstructive phase, there will be cyanosis.
That occurs only in a later stage when the child becomes Eisenmenger with reversal. So from the history, how can you say this is hyperkinetic pH?
Cardiomegaly from examination.
History.
Fast breathing.
Child is symptomatic, no? Heart failure is there, failure to thrive is there. So that indicates it is hyperkinetic pH. So what happens when the child goes into obstructive phase? The symptoms
These
will
symptoms
disappear.
stop. These symptoms will disappear, and there will be no cardiomegaly.
Yes, no cardiomegaly. And what other clinical examination finding will not be there if it was an obstructive pH?
That is the split test too, madam. It will be narrow.
S2 can become narrow. Then
narrow.
Other than that?
Somebody has already mentioned no flow murmur.
MDM won't be there.
MDM and S3 won't be there. So this child is definitely has pulmonary hypertension, which is hyperkinetic and not obstructive. So your second sound explanation of the second sound goes with the clinical
VSD.
case. Okay.
So after the history and examination, we have come to this probable diagnosis, which is acyanotic congenital heart disease, post-tricuspid shunt left to right, most likely large VSD left to right. In cardiac failure,
why is it not a pre-tricuspid shunt? Why do you say it's a post-tricuspid shunt?
Because, madam, child is symptomatic. Already in features of cardiac failure is there. Then pulmonary hypertension has also already.
Okay.
So these are all favoring post-tricuspid shunt.
What else in the clinical examination, cardiovascular examination?
Sir, volume overloading the LA-LV.
Okay, LV volume overload. You are getting a forceful apical impulse. You are getting an MDM and S3. All these are against a post. That we will not get in the pre-tricuspid shunt. Okay.
So this will be a post-tricuspid shunt, left to right. Most likely large VSD, left to right. Child is in cardiac failure, which is class 4 ROS because symptomatic in rest also. Pulmonary hypertension, which is hyperkinetic. Failure to thrive, severe underweight, wasting, and anemia.
Okay. Why do you say it is a large VSD?
Child is again symptomatic, has features of cardiac failure. There is cardiomegaly, pulmonary hypertension already set in, and there is no thrill also. So it is not a small or moderate. So it is a large VSD.
And more important, one more thing is there.
The flow murmur in the MDM and also the LVS3.
Okay, that indicates it's a large
VSD.
Okay, why is it not a PDA? Can it be a PDA?
Yes, madam, but from examination itself, pulse, when we have come to the pulse, we have, and also BP also, the pulse pressure is normal here. So it is not PDA. It's not wide pulse pressure as in PDA. Then the classical murmur. No, the location of murmur, it was classical of VSD and not of PDA.
Okay. What is ROS classification?
No. You answer that. What is ROS classification?
Sir, so we are basically, from the symptoms, we are trying to classify the cardiac failure state. So it's class 1 to class 4 by ROS classification. So the class 1 is the child will be mostly asymptomatic. The class 2 will be, there will be mild features of exertional dyspnea in older children, or in infants there is mild.
No, you are wrong, Aruthi. Rose classification, is it for older children?
No, young infants.
Then why did
So
you say
feeding
older?
difficulty? Sorry, madam. Feeding difficulty and diaphoresis. In that is occasional, or then class 3 was there is associated feeding difficulty, diaphoresis on feeding, that is there, and also there is growth restriction is also there in class 3. Class 4 is this child will be symptomatic like this even at rest.
Okay.
So what I was asking is there any other diagnosis which can fit in out of our differential diagnosis?
AV canal defect is...
AV canal defect, is it possible?
But there will be a murmur of mitral regurgitation, but it is not. That's a point against.
That will be very difficult to find, no? Because you already have a pansystolic murmur.
Pansystolic murmur is there.
So that is still possible. Hello, madam?
S2 will be
Yes, AV canal defect is possible.
AV canal is possible. What about L-kappa? Can L-kappa present like this?
Yes, L-kappa can present like this, but
can it
usually
explain
earlier.
Yeah, it is usually earlier presentation.
But after a clinical examination, are you happy to say L-kappa as a differential diagnosis?
No.
Why? What are the points, clinical examination findings against L-kappa, or what will be the clinical examination findings in an L-kappa?
Really sure.
Gayatri, what will be the clinical examination finding in an L-kappa? Gayatri. Parvati. Anybody? What will be the clinical examination? Will you get a 3/6 murmur, MDM, 3/6 pansystolic murmur, and an MDM in an L-kappa?
No.
No. What will be the dominant finding? So it's an LV dysfunction state, no? So what will be the finding? There will be cardiomegaly with a dominant S3. Cardiomegaly with a dominant S3 will be the finding. It will be like myocarditis. Can be after clinical examination, it can be a differential diagnosis of myocarditis or a dilated cardiomyopathy, where the prominent finding will be cardiomegaly with an S3. Murmurs may not be very prominent. So a prominent pansystolic murmur and an MDM rules out L-kappa, myocarditis, dilated cardiomyopathy, all are out from the diagnosis. Okay, after clinical examination.
Okay, ma'am.
I'm not sure it rules out because L-kappa can cause severe mitral regurgitation also. L-kappa, one of the presentations is severe MR. So they can also have pansystolic murmur, and severe MR can cause an MDM also.
That
severe
can
MR
occur.
itself can cause an MDM.
MR can be there, but when there is LV dysfunction, you may not get a prominent MR murmur. LV has to pump adequately. LV has to pump, has to have a good ejection fraction for the MR to be audible. Otherwise, when the L-kappa presents with severe LV dysfunction, even though by echo you will be able to see an MR, but you won't be able to auscultate a prominent MR murmur. Once you start on drugs and when the LV function improves, like in myocarditis, the MR murmur may appear. But when there is LV dysfunction, you will not get a prominent murmur. So a prominent murmur, MR murmur, is against the diagnosis, clinical diagnosis.
So after this diagnosis,
one point, Arati, we have discussed P2, narrow P2 in PDA. Okay. So basically it is possible, but in a PDA, most of the time, you won't be able to make out the details of the PDA because continuous murmur, the peaking is at the second sound. Okay. So it is happening actually, it is narrowing is happening, but it is very difficult to make out. Okay, go ahead.
So next few slides will be, I'll be showing the chest X-ray of the patient.
In the clinical examination, the diagnosis, did you mention about the liver and spleen?
Sir, actually, this is the slide. So I quickly went on to the summary slide. Sorry, sir. So coming to the
at the end of examination, when you're presenting the diagnosis, full diagnosis, all these things should be coming. Okay, that's right.
Okay, sir.
Including the nutritional status, micronutrient deficiency, because based on that, you are going to answer the question, what are your plans? Okay.
Okay. So for this child, the liver was palpable 2 centimeter below right costal margin. The span was 5.5 centimeter, which was normal. So it can be a push down liver. So there is no splenomegaly. And other systems, respiratory system, the child was tachypneic and there was increased work of breathing, but the chest, the breath sounds were heard bilaterally equal with no adventitious sounds. And the CNS system examination was within normal limits. Now, next slide. This is the picture of the chest X-ray of the child. Madam, shall I explain? So this is a plain chest X-ray AP view with okay exposure, adequate exposure. It's a levocardia. It's levocardia. The liver is there in the right side, and we can see that there is moderate cardiomegaly. We can quite make out if it's an upturned RV apex or an LV, but there is cardiomegaly prominent, and we can also say that there is left atrial enlargement because of the is my cursor, can you see my cursor? It is actually
yes, we can see.
Okay. So there is a shadow in shadow appearance here, and also that might be that visible, but there is carina widening also. And the left atrial appendage is prominent. So overall, there is a left atrial enlargement that is prominent here. And other thing that is prominent is also the increased pulmonary vascularity. So we can see that the pulmonary vasculature is actually prominently being seen extending into the lateral 1/3 also, and multiple end-on view of the vasculature at the hilum area. And there is a prominently dilated MPA. So from this, we can find out that there is cardiomegaly, left atrial enlargement. So there is a volume overload. So there is a left atrial enlargement, and there is increased pulmonary blood flow.
So does your diagnosis go? This X-ray go fit with your diagnosis? Fitting with your diagnosis?
Yes. Yes, madam. This X-ray is fitting with my diagnosis because if it's a large VSD with a prominent shunt, large VSD, so we are having cardiomegaly with increased pulmonary vasculature as is evidenced by the LV-LA overload and the LVS3. So these are all features suggestive of a large VSD.
No, in the X-ray there is LA enlargement, so it has to be a post-tricuspid shunt. Okay.
Yes.
Or
yes.
pre-tricuspid, it has to be a post-tricuspid shunt. And what is the point in favor against PDA in the X-ray?
The aortic knuckle is not prominent, madam. The aortic knuckle will be prominent in PDA. So it is not prominent here. So that will also favor to VSD.
Arati, in the X-ray, when you are reading the X-ray, you should be careful because people will be watching. In the here, a little bit underexposed is the X-ray. Little underexposed, and it is not fully inspiratory. When you're commenting, these are important in a radiological evaluation of the heart because LA is enlarged. I was looking at the what? Shadow in shadow. I was the bifurcation of the carina. Okay. So the intercostal, the intervertebral disc space are not seen in the upper part.
It's not.
What I'm interested is about the bifurcation of the trachea, LA enlargement, if it is lifted up and all. So those are very important. A little bit of rotation also is there.
Yes.
A little bit under penetrate X-ray, a little bit rotation is there, and it is not a fully inspiratory view.
Please, better.
Okay, okay.
What are the other possibilities? Based on this X-ray, can this be a myocarditis or a dilated cardiomyopathy? Or an L-kappa? Is it possible? After seeing the X-ray, will you rule out this? Or will you consider myocarditis,
Yes.
dilated?
We will have to consider, madam.
Why?
Because cardiomegaly is a prominent feature.
Yes. How will be the pulmonary vasculature in a myocarditis or a cardiomyopathy? Or an L-kappa, where there is LV dysfunction, what will be the pulmonary vasculature? Will it be like this? What do
No,
you expect?
actually. No, it won't be
What
like
do
this.
what do you expect?
Pulmonary vasculature will be less, or the
what is a pulmonary vascular abnormality do you
Finding
expect in a myocarditis?
which zone finding? Upper, middle, or lower zone?
When
there is an LV, which zone will be finding? It's an arterial or venous?
Sir, LV dysfunction. No, aortic.
Aortic ano?
LV dysfunction. I didn't understand the question, sir.
In the X-ray chest, in a case of LV dysfunction, where you get a left atrial pressure high, which area in the chest? Is it in the upper zone of the lung, middle zone, or lower zone? You expect the finding. And what finding?
Hilar.
It's not hilar. It's a venous congestion of the upper zone.
Okay. Yes. Yes.
And madam was talking. What about the cardiophrenic angle? What is the cardiophrenic angle in this case?
It is actually not oligemic, but it's a normal costophrenic angle with the.
Lakshmi, carry on.
So if it was a case of LV dysfunction, you will get features of pulmonary venous hypertension. Okay, the vascularity, it won't be a increased pulmonary vascularity, you will get venous hypertension, because when the LA pressure is high, the pulmonary venous pressure will be high, and you will get prominence of upper lobe veins. And there will be features of interstitial edema, like Sir was telling about curly ABC lines. He was mentioning about the cardiophrenic examination of cardiophrenic angle there. No, you have to look for interstitial edema. Okay, so there will be pulmonary venous hypertension. That is totally different from this. This is increased pulmonary blood flow. Okay, you are getting prominent pulmonary arterial vascular markings. The other thing, it will be pulmonary venous hypertension due to increased LA pressure. So seeing this X-ray, you cannot diagnose a dilated cardiomyopathy or a myocarditis.
Okay, madam. So coming to the ECG. So from is it visible for everyone? I'm not sure, but when we come to the ECG, we can see that it's a situs solitus levocardia. Situs solitus as established by P positive in 1 and AVL and negative in AVR, and levocardia in that the R height is increasing from V1 to V6. But the prominent thing here is the and commenting on the QRS, the QRS it is it is coming to the rhythm. It is a sinus rhythm. QRS is normal axis, actually equiphasic in 1, and in AVF it is positive, so it is 90-degree axis, which is normal for the age. And the V1, the R by S ratio, if it's, can you see the V1, the R by S ratio, it is approximately like 8/5, so like 1 approximately is 8/5. So what we are seeing then mainly is in the V5 and V6 leads, we can see that the R, even though it is cut here, the R and S waves are prominent. We have tall R and S waves, and Q is not that prominent. So there is LV volume overload that can be seen in ECG.
Why do you say there is LV volume overload? based on this ECG?
In V5, V6, the S waves are both R and S waves are prominent, madam, but Q is not there.
So what does that indicate? Do you expect a Q or you do not expect a Q in volume
Actually,
overload?
we expect a Q.
So
We
that is the
expect a
point
Q.
against, no? Here you are
Against,
not getting a prominent Q in
no.
V6.
Yes.
So when there is LV volume overload, you usually get a prominent Q with a tall R. Okay.
In
Tall
V5.
Tall R can be due to volume overload or a pressure overload. But in pressure overload, you will not usually get a prominent Q. But tall R with a prominent Q means LV is volume overloaded. But that Q is not seen here, but you can see large voltages, R waves, prominent R waves in V6. Okay.
What else will be there in the V5, V6 in the case of volume overload? V5, V6, you said the Q, however, I look.
Prominent.
Okay. What else? Which other wave indicates a volume overload of LV?
X.
In this case, it is not the T wave.
Yes, sir.
T wave.
T,
In this case, a tall T wave you expect. What? V5, V6.
But it's not there.
And tall T waves. In this case, T wave is not tall.
Not tall.
Okay. So you need to mention about the P waves in the lead to V1 also. We are postulating hypertension. Okay. In this case,
yes. Yes, sir.
V1 in the
lead to
tall P. V1.
There is actually no LA enlargement.
No.
LA enlargement is not there.
LA illa, RA കാര്യം ഇല്ല അല്ലേ?
ഇല്ല.
But V1 only the negative component is same. P wave, only the negative component is same.
But that doesn't satisfy the criteria for LA enlargement. That is not very. So there is no evidence of LA enlargement, but there is evidence of LV volume overload by a prominent tall R waves in V5, V6. But point against is you are not seeing a prominent Q wave and the T wave is not also very tall. Okay.
Is
so
it
ECG is
classical ECG of what you expected?
No.
Classical ECG in a VSD situation, or is it suggestive of a VSD pH? And the classical ano EEC?
Classical alla sir. Because LV volume overload രീതിയിൽ കൂടുതൽ വരേണ്ടതായിരുന്നു. അപ്പോൾ അത്
So you are not happy with the absence of a Q wave.
No.
You are not happy because Q wave is not there, but tall R waves are there. There are some features of LV volume overload, but LA enlargement is also not there.
Not there.
What is the typical pattern of ECG in a large VSD, infant VSD? What do you call it?
Mid chest leads.
Katzwachel. That is in biventricular hypertrophy. So in mid-precordial leads, V3, V4.
pH,
Mid-precordial leads V3, V4. The component of R plus some will be more than 60. So
component of R plus S will be more than 60.
Suppose this ECG was showing right atrial enlargement, peaked P waves. What will you think?
Gerbode VSD.
Very good. Can be Gerbode VSD. What else? Will you be happy if you see a tall peaked P waves in this child?
I can't.
We will not be happy. We will think that whether the child is going into obstructive phase of pulmonary hypertension. You see,
so surgical
prominent
correction.
peak P waves are there. So you expect an LA enlargement, but if you're seeing a RA enlargement, one thing is Gerbode VSD can cause RA enlargement, or you have to think whether the child is already going into an Eisenmenger phase.
TVOD,
or you can you consider any other differential diagnosis?
No, madam.
AV canal defect, sometimes you can have right atrial enlargement also. Biatrial enlargement can be there, no? In AV canal
Okay.
defect. That is also a possibility. Okay.
Okay, suppose in the clinical examination there was an irregularity. And in the ECG also it's not regular. Irregularity. When you are considering Gerbold shunt and all, is there a possibility of irregularity in a VSD? Or a heart block situation, low rate? Is it possible?
Perimetrance.
Can an arrhythmia occur in a VSD on follow-up? Which arrhythmia?
Heart block.
Mechanism?
Sir, like post device closure. If it's a perimeter.
Without any intervention, is it possible?
Don't know, sir.
Suppose it's a moderate or small VSD on follow-up. It's not a case like this. What is the mechanism of closure of a small VSD?
It can be due to STL aneurysm or RCC prolapse, right coronary cusp prolapse, or due to yes, RCC prolapse. Can go. Actually, I don't have that much idea.
It's a rare situation.
Okay.
JVP evaluation also is important. We are considering two possibilities. One is a pH situation, another one Gerbold shunt. Okay, in those situations, what do you expect in the pH in a JVP? It's difficult in a
wave stall A.
Significant A wave when there pH with TR and Gerbold shunt even taller JVP. It's difficult in a 9-month-old child. So that's the importance of JVP examination.
JVP. Okay. So next few slides are on echo of the child.
Okay, discuss.
So
can you show the cursor Arati while I'm speaking? So that.
sir.
So what she's showing now is the dilated LV and the LA down is the LA with the mitral valve in between. And on the right side of the screen, it is the RA and RV. So compared to RA and RV, LA and LV are significantly dilated. Yeah, you go on to the next. So in the previous picture, we did not see any defect between the LV and the RV, but here you can see it is slightly modified apical 4-chamber view. Again, LA-LV on the left side and RA-RV on the right side. There, what she's pointing now would be the defect, the red color flow from LV to RV. So that red color flow is the VSD flow, shunt flow, and it is left to right in direction. Yeah, go on to the next. So this is a short axis view. This is just to show that although it is not an audible murmur, the patient also had a very small PDA. You can see that red color flow towards the left of the screen. That is a flow from the descending aorta, that round structure below that, to the main pulmonary artery. So that is a small PDA. Next. So you can see the LA. This is a parasternal short long axis view. The lower down, that 20 millimeter, that is the LA. That's a dilated LA. You can see compared to that, the above one, that is the aorta, it is only 10 millimeters. So no, that is LV. So what she's showing now is the aorta. Just below that is the LA. So LA is significantly dilated compared to the aorta. Next. This is again a short axis view. The round structure is the aorta with the aortic valve. And you can see there is a red color flow with a defect. You can actually see the defect in that without color, that image. Yeah, that is the defect with a left to right shunt. That is from LV to RV connection. That's a large VSD. It measured around 7 millimeters. Okay.
Thank you, sir. So with that, we have come to the end of the case discussion.
How will you manage this child? One more question. How do you classify VSD as mild, small, moderate, and large?
Madam, by QPQS
By
ratio,
by echo. We just showed the echo, no? Based on echo.
size, based on the size,
Not
Based on the
based
size
on the
of what?
Size of the
We'll
defect and the palm and the
Aortic root. You will compare the VSD with the aortic root. Okay, if it is less than 1/3 of the size of aortic root, it is small VSD. 1/3 to 2/3 is moderate. More than 2/3 the size of aortic root, or equal is the large VSD. That is based on echo. Okay. And how will you manage this child?
First, we will have to start the child on anti-failure drugs. Diuretics, the child has been already started on that from 6 months of age. So already past 3 months, the child has started. Child is showing no improvement, so child will require surgical.
Any other drugs? Any other drugs will you start other than diuretic? Is there any role for digoxin?
Digoxin, yes, madam, we'll use actually, but for this patient, I'm not sure. Actually, digoxin we'll use as an.
What is digoxin? It's an inotrope, no? Digoxin is an inotrope.
Yes.
How will be the LV function in a VSD?
LV is overload, so
ejection fraction will be normal or above normal. Okay, then why do you use digoxin in a child with post-tricuspid left to right shunt? What is the role of digoxin?
We are increasing the afterload, so
the digoxin will it increase afterload?
No.
When will you start digoxin? First, we will start on diuretic, and when will you consider digoxin also? Suppose the child is having tachycardia, you can add digoxin. Okay. And digoxin has some weak diuretic effect also. So that is the reason why we use. Okay.
Okay.
Any other drug? Any other drug? Somebody at a Gayatri is telling AC inhibitor. So what is the role of AC inhibitor in the large VSD? Somebody is telling beta blocker. Will you start beta blocker in the large post-tricuspid shunt? Will you start beta blocker or not?
No, madam.
Beta blockers are not indicated in post-tricuspid shunts. Okay. Which other drug? AC inhibitor. Okay. What is the role of AC inhibitor? How will it help in a post-tricuspid shunt? Reduces the afterload. Okay.
Reduces that.
Afterload. So decreases the shunt. So whenever the afterload increases, the shunt will increase across the VSD. Yes. That is why when a child has associated coactation, the VSD can become symptomatic. No?
Yes.
So we have to keep the afterload low. So for that, AC inhibitors may be started. Okay. Then what else will you do? Child is on diuretics and child is having heart failure and failure to gain weight. So what is the next option?
Surgical correction. That's
okay.
The next
this child will need early surgical correction of VSD. Okay. Purushothaman sir, any other questions?
You need to read a lot more because you are going to appear for the examination. കുറേ കാര്യങ്ങളുടെ അകത്ത് പോരായ്മയുണ്ട്. മനസ്സിലായോ? ഞാനിപ്പം കൃത്യമായിട്ട് യഥാതഥമായിട്ടാണ് പറയുന്നത്. ആൾക്കാരെ ഫ്ലാറ്ററിയോ പിടിക്കൊന്നും കാര്യമില്ല. Lot of areas you need to improve. പിന്നെ for a pediatrician's point of view, there are a lot of role for a pediatrician preparing the child for the cardiothoracic
surgery.
The nutrition part you need to improve. How? That will be question. Okay. How are you going to improve the nutrition? What are the other roles for you? Micronutrient deficiency and vaccination is not vaccinated. About
9 months
pediatricians, what all things are there in such a case? And post-surgical, post-intervention follow-up, what are your plans? all those questions you need to prepare for this. High dense energy nutrition, small frequent feeds, and considering the possibility of an associated GERD and development of yeah, okay. Then only they'll take up for surgery, but they cannot delay too much because the patient is already having PH. So we have to hand over to the cardiothoracic team at the earliest, completing the role of the pediatrician. Okay. Okay, that is a very, very excellent discussion, Lakshmi, Hari.
Yes, thank you, sir.
Riyas undo, Srijithe?
റിയാസ് സാറിനെ
Das undo?
അല്ല റിയാസ് സാറ് ഇപ്പം പ്ലാറ്റ്ഫോമിലില്ല.
അപ്പൊ കുഴപ്പമില്ല, നമുക്ക് വൈൻഡ് അപ്പ് ചെയ്യാം. നന്നായിട്ട് ഡിസ്കസ് ചെയ്തിട്ടുണ്ടായിരുന്നു എല്ലാം.
നമുക്ക് സ്റ്റോപ്പ് ചെയ്യാം സാറല്ലേ സാർ? Okay, I invite Dr. Sujit Kurian for the official vote of thanks. He's a PG coordinator.
Okay. Okay, thank you, sir. Okay, it was an excellent discussion actually, and Lakshmi Madam and Hari covered all the points. Actually, that's will be very helpful for their exam. Covered all the questions that should be expected in exam. And as always, I am thanking Purushottam sir for his excellent contribution. Okay, and our PGs also they are thanking PGs for their active participations. Okay.
But thanking especially Parvati and Gayatri. Okay. I expect the PGs to come forward and participate in the discussion in the coming sessions. അത് വരുന്നില്ല പലപ്പോഴും. നമ്മൾ ക്വസ്റ്റ്യൻ ചോദിച്ചിട്ട് ഇങ്ങനെ മിണ്ടാതിരിക്കുക. സമയം വെറുതെ കളയാൻ പാടില്ല. All the PGs hereafter should be part